So how do you talk about something you've done for 10 years in 15 minutes? I eliminated all molecular stuff, stayed with the clinical stuff, the impact that our regenerative work had on our patients. So I'm going to discuss the justification for our work, exemplify the surgical and regenerative technique, and demonstrate the outcome that we have had in the past 10 years. Before I begin, I'm introducing you to two of our patients. The dog on the left sustained a gunshot wound from the right eye to the left mandible with severely comminuted fracture, lots of bone are missing. So is the owner, by the way, except that only the dog survived the shot. The dog on the right had non-union in her left leg forelimb, which, as you can see, it's a defect non-union that was repaired or attempted to repair 5 times, and the owner brought the dog for amputation. So here we have a situation where we have 2 patients, 2 dogs. Both of them have defects in the bone. One is mandible, one is leg. So what do we do? As a maxillofacial surgeon, I need to realize that I really need to fix this mandible. I need bone. Where I'm getting this bone, autologous bone, I can go and get from the humerus, I can get it from the hip, but it's not reliable. I really cannot get large enough number. The dog that I showed you earlier with the mandible also have von Willebrand disease, so good luck getting bone marrow from this dog. Okay, so where do we go from here? We go to regenerative medicine, and so I will not do justice to our work without looking at the history a little bit. So this is the second time you will hear the name Marshall Urist. One of them was earlier with the context of an award that was given to somebody. So Marshall Urist is considered the father of modern tissue engineering, started his work at UCLA in the 50s and 60s. Basically found this molecule that they determined to be bone matrix to stimulate new bone, coining the term bone morphogenetic protein. Later came his postdoc, Dr. Harry Reddy, which I'm proud to consider as a colleague and friend. He was one of my mentors in my postdoc. He still lives in Davis. And so he introduced me also to this molecule and how to work with it. In 2002, FDA approved it for spinal fusion and some dental application. So that is where everything started. BMP itself, okay, is when we talk about bone morphogenetic protein, we talk about morphogenesis, which is the process of forming structures in the body. And the morphogens are signals that initiate and govern tissue formation. And everything there is based on reciprocating interaction. Specifically for BMP2, that can do many things that you can see here. It have an inductive effect for chondrogenesis and osteogenesis, so we're able to form bone and cartilage depending on the dose. So why do we need to reconstruct bone defect? In this case, the mandible. When you have a mandibular discontinuity or lack of continuity, it will have effect in a way that the mandible will start drifting to the side where you have a defect. This in turn will have effect on muscle of mastication. Long-term effect will have TMJ, alteration and pain, and can lead to arthritis. If you don't believe me, for the rest of my talk, just move your mandible with one finger to the left or to the right and see how you feel in 5 minutes. So that's how it feels when there is lack of continuity. So this is dogs, okay? And here what we see is a dog that did not have reconstruction. This dog is about 8 years or so after the reconstruction. Their owner struggles throughout life when the tongue is hanging down and there is staining. The dog is on antibiotics all the time because of dermatitis. The dog on the left wearing a bib, exactly for the same reason. So as oral maxillofacial surgeons, I know we can do better, okay? When we look at people, they were where we are now in the 80s. until they decided that reconstruction is the way to go. People that have discontinuity of the mandible or defect have alteration of the kinematics, the movement. So this is a slide that I got from my colleague Sabine Linsen from Germany, from Bonn, looking at before and after reconstruction in people. Okay, people that have discontinuity and alteration of the movement of the mandible. They cannot speak right, they cannot eat right, they cannot find a partner, they cannot find a mate, they cannot go to work. So it has a lot of effect on people. We did a similar job, similar work in dogs, although it was done on cadavers, and the kinematic work on cadavers showed us we could quantify the movement of the mandible. I know that the literature is confusing as far as if you have discontinuity of the mandible or segmental defect, if there will be, changes in kinematics or drift. There is a drift after mandibulectomy, and I hope that that it goes down, that we understand that part of the mandible is missing, the mandible will start drifting. So there are no surprises there. So we know that we need to do something with these floating jaws. So our hypothesis would be that if we integrate our reconstruction regenerative efforts with the use of collagen, hydroxyapatite, 3-calcium phosphate scaffold that will be infused or saturated with human recombinant BMP2, it will result in quick and predictable bone formation and return to normal function. Dr. Volk talked about scaffold. I'm not going to talk about scaffold too much. Just to say that we are using signal. The signal will be BMP2 scaffold, which is hydroxyapatite, 3-calcium phosphate, and collagen. And the cells that are in the immediate vicinity of the scaffold. So we're not injecting anything external. The BMP is going to recruit the cells. We're using CRM, which is the scaffold. It's called compression-resistant matrix. The collagen, hydroxyapatite, 3-calcium phosphate. It's a mastergraft matrix from Medtronic. I should have said in my disclaimer, I'm not getting, I don't have any conflict of interest. None of the companies pay me, unfortunately. rhBMP2, we also get from Medtronic. These are donated to us for compassionate animal use. And the soak volume is 50%. What you see here on the slide is what we use. As far as implants, we're using the same bone plates and screws as are used in people, which is titanium locking reconstruction plates from Synthes. Again, no conflict of interest there. Or 2mm locking mini plates in smaller dogs. 3D printing for surgical planning is something that we use quite often. For example, this dog that came to us from Maine for reconstruction, you can see that there is a defect in the mandible. What we do is image the dog CT and then use the CT and create a mirror image mandible and print it. Now we have a mandible that you can see here, and the left that is intact. We'll take the plate, we will contour it according to the normal architecture, normal configuration of the mandible, and go to the OR with a pre-contoured plate designed specifically, personalized medicine type to this patient, reconstructed with BMP. The dog came on Monday, left on Thursday afternoon with a new jaw. So we'll talk about, I'll show you segmental reconstruction, which is one type of reconstruction that we do. This is a myeloblastoma. You'll need 10 millimeter in each side to get clean margins. We do this. So that's a cartoon to show basically the principle of the surgery. We first place the plate. Now we do these things on 3D. Printed skull. The piece is taken out by mandibulectomy, and the pre-contour plate goes to place. This is the scaffold is fused with BMP, and the idea is that it will form bone. Okay, the surgery takes between 2 hours and 4 hours, depending on the magnitude of the reconstruction. And then we have the bread and the butter. These are the defect non-union dogs, typically very small dogs, Yorkshire Terrier, and this kind of size of dog that have periodontal disease. They break the mandible, they have infection, you take the teeth out, you have a defect, and then we have to reconstruct it. Autologous bone grafts are not really relevant for these dogs. You cannot really take bone from a very small 2 or 3 kilo dog and fill a defect. And then we have, I think that this one has to operate like this. Then we have a rostral reconstruction. Like I showed you earlier, the dogs that have to amputate both mandibles, so bilateral rostral mandibulectomy. These dogs typically have the tongue hanging out, staining of the chin. So if we can improve on this situation, why not? Okay, so that is these plates are typically contoured on the 3D model. It's also a 3D model, also a good one for resident training and practice the surgery beforehand. And then the scaffold, as you can see on the right, will be implanted. And the idea is that it will form bone. And then we have the more extreme situation of extensive reconstruction, those that need to have extensive mandibulectomy. We reconstruct them, and that's before and after. So as far as mandibles, we've done so far 44 dogs. About half of them are not from California. They come over. So when we established the reconstructive program, it was, if you build it, they will come. So it's good for building a regenerative program. If you offer it, people will come to you. And you can see here, we did 11 segmental reconstruction, 8 bilateral rostral, 22 defect non-union, 2 gunshot wounds. I've shown you one earlier. We will meet this patient later on. And 1 extensive for fibrosarcoma. Follow-up, we have up to 10 years. We have had normal occlusion in all of the patients. At 2 to 4 weeks, you can already palpate hard bone formation or hard tissue formation. The oral mucosa was intact in all dogs, except 2 that had plate exposure, and we have dealt with this. We've had 1 recurrence of a tumor out of these 44 cases, which it's out of the scope here because it came much later, and we're not sure yet it's because of the BMP or not. We have CT follow-up on all of the dogs, and on a subset of dogs, we have at 1, 3, 6, 12, 24, and 60 months, which is something that we're writing up now and will be published. 2 dogs, we have histology. I'll show you in a second. So here are the CTs. What you can see here is the regenerated bone, and this is the native bone. Okay, and these are 3D images to show how that these look like. When we quantify this, we see that we achieve about 50 to 92% of the density of the contralateral mandible. The bottom line is that when you have a plate bridging a defect and a bone that is load, the bone that forms really quickly, that is load sharing, it also helps the bone and the plate not to fail. Okay, the same thing for rostral mandibular reconstruction. We do see new bone formation. It's very consistent. It's very predictable. What you see here, that little bit of the bone is missing. This is the dog that had plate exposure. We had to remove some of the scaffold. But the bottom line is that there is some fibrous tissue there, bone formation here, and again, fairly good outcome for these dogs. What we also see is that when you start working these mandibles immediately after surgery, you're not only having signals from the BMP, you also have mechanotransductions, mechanical influence on bone remodeling and formation, and that also leads to structure-function relationship. If you look good at this bone, you will see that it now developed 2 cortices, or cortex-like density, and almost like a mandibular canal, I want to say. But the general thing is that this quick return to normal function also translates to appropriate structure-function relationship. This is one of our patients that died, clearly, from something not related to this clinical work. He had the aspiration pneumonia later on. The owner donated the dog to us so that we can do histology. And you can see I took a core from the center, but we also took from the interface. And the histology of this show you that we have a woven immature bone, lamellar bone that is more mature, with osteons in the mature and still no having osteons in the immature, but that is, again, that's 6 months after reconstruction. We can also look at the electron microscope and we see the osteoblast and we already see the osteocytes. So we documented that what we are regenerating have all the features of normal bone, okay? And this is the dog I showed you earlier that received sustained a gunshot wound, reconstructed it. This is already 4 years later, having a more or less normal life without an eye, but with a good mandible and happy. Okay. As far as appendicular bones, when we were in the middle of our jaw reconstruction regeneration program, our orthopedic surgeons also wanted to start working with it. So we are collaborating in it. To date, they've done 47 dogs with different long bones or for arthrodesis. They love it for arthrodesis because you don't need to bring bone graft and it's fairly predictable. And you can see the numbers here, which is very impressive. And this is the dog I showed you earlier that came for amputation. We talked with the owner and they wanted to try reconstruction, okay? And this is the dog now. So, a short movie speaks more than 1,000 words. She also fractures the contralateral leg right after this one was healed. And that's not the only case that did this. Which leg, from what you see here, is reconstructed? The one on the left? Okay, both of them. The one on the right already had the plate removed. The whole thing is BMP. She had the defect non-union like you were seen earlier, and orthopedic surgeon reconstructed it with BMP. The whole thing is BMP. Again, structure-function relationship. When the bone is formed, they adapt and they not only regenerate, becoming almost like a normal bone. So that is what we have here. And that is from our recent publication, showing you that it's consistent throughout our patient. And you can see that, for example, here, more than half of the bone is being reconstructed and regenerated, which is fairly awesome. These are the papers we published on this so far. And we have a 10-year outcome coming soon on mandibular regeneration. So in conclusion, regenerative approach using BMP has been really great for us. It's predictive with really good long-term outcome. We avoid the need to harvest autologous bone. We're incorporating 3D printing for surgical planning has been great for us, but it does require careful handling of the growth factor, and which is probably why it's not widely available still. And this dog that you see here, it came to us from Montana for reconstruction, and that had the same type of surgery that you've seen earlier with the dog that had the tongue hanging. So you can see the big difference. Thank you so much. Happy to take questions.